Okay, so as she said, we're going to be talking about sensory integration today. My last name did change, so I'm Jennifer Orcholi now. I've been at St. Luke's North in PEDS for 6 years. I got my certification in sensory integration through USC and WPS back in 2014, and then I went on to get another certification in sensory integration through USC, and I completed that in, it was either 2017 or 2018.
My name is Wooldridge. I work at St. Luke's Pediatrics, the North location. I've been there now for about 2 years. I graduated from Alberta University with my Master's of Science in Occupational Therapy, and I just recently completed the Sensory Integration Certificate through USC.
So we have a disclaimer. So the objectives of what we're going to talk about today, we're going to discuss the core concepts of AIR sensory integration theory. We're going to talk about 2 different types of sensory processing dysfunction, and then go more into detail about the different areas. So we'll get more into that later. But those 2 types are sensory motor and sensory modulation. So that handout is really helpful as we go through this. I'm going to refer back to it multiple times just to give you a nice visual about the different types that we're going to talk about. Then we're also going to talk about how to analyze the data using clinical observation in our evaluations, also parent report, standardized testing, and then we're going to talk about how to implement the AIR sensory integration approach. We do have a case study with one of our kiddos. It's very different with every child, so it just gives you a nice idea. I have some videos that I'll be able to show you later that I think will put a little bit more meaning to it. So who is Jean Ayres? Jean Ayres was an occupational therapist. She received her bachelor's in OT in 1945 and then went on to receive her master's in OT in 1954. Soon after that, she received her PhD in educational psychology. Jean Ayres developed the sensory integration theory and then also was a huge role in the sensory integration and praxis test. She has her own clinic in Torrance, California. She's since passed from breast cancer, but it is still open today, and all the clinicians there are still using her approach. Actually, a lot of the clinicians that work there still did research with her and worked with her directly, so they taught a lot of the courses. It was really cool to hear some of the things that they had to say about her personally. So what is sensory integration? It's a central nervous system process, and then Jean Ayres described it as the neurological process that organizes sensations from one's body and from the environment and makes it possible to use the body effectively in the environment. So everything that we do in our daily lives, we're taking in sensory information, and we're using that and integrating those senses to feel organized and be able to perform at our best. So even something as simple as today, where there's not much going on around me, but having people's eyes on me, you know, I'm having to take in this information and be able to perform and organize my thoughts to perform at my best for you guys. So AIR sensory integration is founded on 4 principles. The first one is neuroplasticity. So that's the ability of the brain to form and reorganize neuronal connections. And that's typically based on learned experience or trauma. Development, so early activity serves as a basis for more complex activities. This is biological, psychological, and developmental from birth to adulthood. And then integration, being able to coordinate all of this input for higher level of function, so motor control, cognition, and then feedback, so experiences shape and form your then behaviors. All of this information then is used to create an adaptive response, which we're going to talk a lot more about as this presentation goes on. So again, sensory integration theory, it stresses the organization of sensory information for functional use. And the focus that we're really going to talk about today is on the vestibular system, the proprioceptive, and the tactile system. This is the 3 major systems that we talk about under Jean Ayres' theory of sensory integration. And then again, the adaptive response, like I said, a response to any environmental challenge. So here is that chart that you guys have. Like I said, I think it's just a really nice visual to look back at each time that we talk about the different systems and how it relates to function. And Nicole's going to talk a little bit about the vestibular system.
So as Jen stated earlier, AIR sensory integration focuses on the 3 main systems. These are the vestibular, tactile, and the proprioceptive system. We're not going to go into the anatomy and physiology of each system. We're just going to give you a brief overview on how it relates to sensory integration. So first, we're going to talk about the vestibular system. The vestibular system contributes to our sense of movement and its gravity, provides unconscious awareness of our own movements through space. It is the primary organizer of sensory information for engagement in all of our occupations. and is also critical for maintaining posture control and equilibrium while performing all of our daily activities. It's important for maintaining muscle control, especially that co-contraction, and then those anti-gravity positions and your extensor tone. And it also modulates the movement of our body and eyes relative to gravity. Within the vestibular system, we have two main systems, the peripheral and the central nervous system, or vestibular system. The peripheral vestibular system responds to inner ear stimulation. It accounts for the angular movements of the head, gravity, and as well as vibration. And it detects our movements of our head through space. And then we have the central vestibular system, which we're not going to go into detail about, but it's those higher level cortical functions. There are two important structures within the peripheral vestibular system. They're the otoliths and the semicircular canals. The otoliths, they detect the linear movement, and then the semicircular canals detect those, the rotary movement, the going through space. And then the vestibular system is integrated closely with proprioception and vision to regulate our balance. Vision plays a huge role in our vestibular system.
So what we want you guys to do, if everybody could just stand up. And then go ahead and close your eyes and slowly sit back down. So when you're doing that, you're using your vestibular senses. A lot of you use your tactile. You're reaching back. Also proprioceptive, you know where your joints are, and you know how that feels to reach back. But then also within that vestibular system, it's letting you know, oh, I'm still upright. You know, not everybody didn't get up and just fall over when they close their eyes. So you're using that to maintain your balance and to control yourself back into your seat. Okay, so developmental manifestations of vestibular dysfunction. There is a lot of information here with all of this, so we're going to do our best to compile as much of it as we can. These courses were 4 or 5. Mine was, the first one was 4 5-day courses, so it's hundreds of hours of this, so just bear with us. I'm going to try to make the most sense of it as I can with all of this information. So if you look at your little handout that I gave you, on the sensory motor one, so the sensory motor perception discrimination, that expands out into looking at the vestibular and postural ocular deficits and bilateral integration. So the first one there's two different types of manifestations within inadequate postural mechanisms. So the first one, these kiddos a lot of times will look low activity level, low muscle tone, kind of just drag. They don't really engage in motor activities. They're, have the hunched posture, poor attention. But then the other manifestation would be a kiddo that has a high energy level and is constantly spinning. So in that case, a lot of times they're still looking for that postural stability. They still don't have those postural mechanisms. And again, we're looking at it at the sensory integration approach. So a lot of times with those kids, we're looking at more of like the otolith function within the vestibular system. So again, observations with these kids, we see they're slow to master gravity. They might be on the later end of normal with gross motor skills. They might be delayed. They might be normal. But you're still looking at, how they perform their daily tasks. What does their muscle tone look like? How do they respond to different movements against gravity? What's their activity level? And like down the road, you'll see them struggle maybe with organized sports, things that require more controlled motor control. And then the next one is the modulation component of vestibular processing. So with this one, we are looking at the over-responsiveness. So gravitational insecurity is the first one. It's extremely rare. Erna Blanche is one of the professors that taught the sensory integration course. And she had even said she worked directly with Jean Ayres, that in her experience in all the years that she's done it, gravitational insecurity was one that she saw maybe 1 or 2 times truly. These kids have an irrational fear of any movement in relation to gravity. So they don't like being picked up. They will not do something as simple as jumping over a line because they don't want their feet off of the ground. So it is one that is more rare. The other one that we see is intolerance to movement, and this one is much more common in our setting. We see a lot of kiddos with this in peds. And in this case, they still, they're still fearful of movement, but it's not necessarily in relation to gravity. So they have trouble with changing in head position. So you might see things like, them having fears of getting their hair washed, and not because of the tactile piece, but because they don't like their head tilted back. They don't like being picked up, when it's not in their control. They struggle with diaper changes. They're, it's out of the ordinary. It's not just a daily, baby crying, it's more extreme, and the parents tend to notice this too. So ways that we assess vestibular dysfunction. The biggest one is clinical observation and parent report. Clinical observation, I'm going to go into more of the skilled observations later, but there are some structured and unstructured. So we're kind of just watching what toys they play with, watching how they move their bodies. A lot of these kids, if they have the intolerance to movement, you don't see them, even if they're sitting on a ball or they're climbing up a ramp, their head does not move. It stays exactly in that position. So you're watching. And then there's some other skilled ones later, so we'll do some different positioning things that I'll talk about. Post-rotor nystagmus is a more formal form of testing, and that one I don't do often, but you can. That one is one that came from the SIP, so within that, a lot of times if you see the seconds of you're eliciting nystagmus with rotations 10 clockwise and then stopping 10 counterclockwise, watching how long that lasts. And usually if it's a higher number, I can't remember exactly what it is, I would have to look back at the SIP, but that typically means it's more of a cortical dysfunction rather than a vestibular that we can address with sensory integration. Standing walking balance is one on the SIP, and then, like I said, parent report is huge. So really talking to the parents, what are you seeing your child do at home? What are you seeing them struggle with? What is something you would like to see them do? And then, looking at what things they'll do with our equipment in our activities within our setting. And the one thing I do want to stress here too, and it goes with all areas of sensory processing, we all have sensory issues. I don't like roller coasters. Our vestibular systems age as we grow, as we get older as well. There are people that love spinning rides and love roller coasters, but is it impacting function? So with these kids, really we're just looking at, if they don't like to go on rides at the amusement park, so be it. But are they struggling in school, sitting upright at their table? Are they struggling, going on the playground or participating in gross motor play with their friends? So back to our chart. Those are the things that we talked about with the registration and discrimination, vestibular postural ocular deficits, vestibular bilateral integration, and then the modulation. We have the over and under responsive.
Okay, so our somatosensory system. Our somatosensory system is actually a collection of several systems that provide information about the body. When in AIRS sensory integration, when they refer to the somatosensory system, they're really referring to the proprioceptive and the tactile systems. So first, we're going to review the tactile system. It is the first system to mature in utero and is the most mature sensory system at birth. It is one of the first means of environmental interactions, emotional and sensory motor interactions with the environment. The general functions of the tactile systems really include the emotional bonding, the emotion and arousal regulation. It evokes a protective response as well as exploratory action, and it contributes to the development of body scheme and praxis, and it's associated a lot with the fine motor coordination as well as like the in-object manipulation, in-hand manipulation. And then we have the proprioception system, also known as the sixth sense. As we all know, it's probably the sense of one's own body involving sensations from the joints, muscles, tendons, ligaments, and the skin. The general functions of the proprioceptive system include detection of joint position in space, the sensation of effort, force, and or graded force of movement that accompany active movement, sensation related to timing of action, and it's integrated closely with our tactile sense. It's also important for the body and segment orientation. The importance of the proprioceptive system in relation to sensory integration, it's really important for body scheme, head righting, there's posture control and balance, and the motor planning, as well as the self-regulation. It can be assessed, tactile and proprioceptive can be assessed in infants. With the tactile, it's the righting reflex, the grasping reflex, and then the proprioceptive, it's those neonatal protective responses. And, motor learning is dependent upon adequate somatosensory processing. So in order to have good motor learning and good body scheme and praxis, we really have to have a good functioning somatosensory system.
Okay, so some of the dysfunctions within the somatosensory system, as it relates to air sensory integration. So the first one we're going to talk about is tactile discrimination. This is the one, again, if you look at your chart, that's going to be under the discrimination and motor part of the chart. And then tactile defensiveness, so over-responsive, which is a modulation concern, under-responsive to proprioception, and then use of proprioception as a modulator. There really never is a over-responsiveness to proprioception, rather than we tend to use that to regulate and modulate our other systems when there's another type of dysfunction. So the first one is tactile discrimination. This one is inability to receive and organize any kind of tactile input for motor performance. So a lot of times when I have my kiddos come in for evals, and I'll do like a little swipe on their neck. So it kind of gives me an idea of tactile defensiveness and tactile discrimination. So if I touch here, usually if they're, hyper aware of it and they're grabbing and they kind of seem antsy and want to crawl out of their skin, that's an indication of a defensiveness. If they have no idea where it is and I touch here and they're touching over here, that could be a discrimination. Or if they have no awareness at all, it could be nothing, but it just gives you a little bit of an idea and gives you something to look more into as you do the evaluation. So behaviors that we see with these kiddos are, they tend to be clumsy. Again, they have trouble localizing tactile input. One of the assessments on the SIPT is you have to touch them with something, or I think it's with your finger, I can't even remember. And you have to actually score, oh, it's a pen. So use a pen, and then they have to do it too. So then you actually can measure how far off they are from it. So it's a little time consuming, but it's pretty interesting to see that. Stereognosis, so you being able to reach into a bag and find something just by touch. And then later on, you see poor handwriting. They might be a messy eater because they don't really know where it is on their face. One thing they had us do in the course, mostly everybody I think has short sleeves on, but if you have long sleeves on, if you cover your hand up with your sleeve and try to reach into your bag and find something, it just gives you an idea of what it might feel like for these kiddos who have tactile discrimination difficulties. They struggle to be able to really get the sensation of what that feels like in their hand. So then the tactile defensive, this is the modulation one. This is what I just spoke about too. So this is typically an extreme aversive response to what would normally be a non-noxious stimuli. Again, we all have our tactile issues. I do not like the way cotton balls feel. I do not like the texture of pudding. Am I a functioning adult? Most of the time, I think so, yes. But, we're looking at how this impacts our kids' function. Are they not doing arts and crafts at school? Are they not walking? Or are they late with walking or crawling because of not liking the way things feel on their hands or their feet? So we're looking at their behaviors and kind of grading, is this something that is really important to work on? So a lot of these modulation kiddos, the big thing is arousal. You see them outside of this optimal band of arousal. So if you can think, if someone's tapping on your back lightly for 10 minutes, and then somebody says your name in the other room, most of the time you're going to respond, what do you want? Because your arousal is going up and up and up as you're being annoyingly tapped with this light touch. This is how these kids feel with everyday things. It might present, if you're looking at it from the sensory integration approach, parents come to me and they say, my kid covers his ears. They don't like the sounds. But then I'm assessing, is there a tactile modulation issue? Is it because they're walking through crowds and they're getting light touch over them rather than the actual auditory component? Not to say there's not, but it gives me something more to assess. So a lot of these kids then will arch when they're held. We see some toe walking. There's a vision piece with toe walking, but I'm not going to go there. We're just talking with AIR's approach. Feeding difficulties, again, struggling with large groups of people, clothing textures. In some cases, we can tell the parents, cut the tags off if the kid's wearing the clothes. But when the problem really becomes they're not changing from summer clothes to winter clothes and they're wearing shorts when it's 0 degrees out, that's when it's a problem. That's when we really need to work on their ability to tolerate that input. So then poor proprioception we have, and this a lot of times goes hand in hand with the tactile discrimination and then also even the vestibular. It's rarely just one of these, but it's good to know what you're looking for so that you can kind of decipher a little bit more what direction to go with treatment. So these kids will see they break toys easily. Again, they appear clumsy and then might have joint laxity. They tend to have low muscle tone, poor co-contraction. Again, we'll talk about some of the skilled observations with those kids that we can look at a little bit later. And then use of proprioception as a modulator. This tends to be, like I said, if you have another type of dysfunction. So the kids who have tactile modulation issues, you tend to see them end up actually crashing more because they're trying to calm their bodies from that light touch. They're trying to inhibit that sensation and get themselves back to that optimal band of arousal. They just don't quite know how. Again, poor graded force of movement. And they sometimes might appear aggressive. There's definitely a line there looking at why, but that's where you're looking at the adaptive response when you do your interventions. And then, as Nicole said, praxis, there's 3 components to praxis. In order to be successful in that area, you need to be able to organize your sensory systems to be able to come up with. Ideation is looking at something and being able to see, I can do A, B, and C with this object. Motor planning, being able to form that sequencing and pattern of things that you need to do with your body, and then execution, actually the motor output. In these cases, a lot of times the kiddos with the tactile or the proprioceptive dysfunction, we tend to see difficulties with praxis. They have no idea what to do with their toys in front of them. So it's really interesting when you look at it a little bit differently when you're looking at it from this perspective. And then back to the chart.
Okay, so the process of gathering all this information and how, we kind of get these kids to us. A lot of times, the first thing that we have is a referral. The parents will go to the doctors, go to the developmental pediatrician, and say that, my son's doing X, Y, and Z, and then they'll refer them for an occupational therapy evaluation. The reason for referral will really allow the therapist to understand the concerns related to functional outcomes. The ideal reason for referral will be provided in more of precise and functional terms. Ideally, we would like to have somebody, like Jen said, my child does not like to change from summer clothes to winter clothes, or winter clothes to summer clothes, versus my child doesn't like to wear tags, or I have to cut the tags out. Another good one is like, does not get along with children, cries when brushing his teeth, brushing his hair, haircuts are really difficult, versus just my child has sensory processing issues. A good, concise referral really allows us to use the appropriate tools to evaluate them. Then another really important part of our information gathering is the caregiver interview. Here we ask a variety of questions to understand the history, their birthing history, how are they delivered, are they meeting their developmental milestones on time, how are they with diaper changes, how are they with sleeping, how are they with their activities of daily function, and how are their play skills. And then we also have skilled observations. We're going to go into this much more detail later. We have our skilled and our unstructured and our structured clinical observation. Our unstructured is really just watching them with free play, like how is their posture, how are they sitting, are they interacting with toys, are they just sitting in the middle of the floor, or are they running all around. And then we have our structured, where we really set up the environmental to clarify information, and it includes the clinical observations that Jen's going to talk about later. And then we have our questionnaires and the sensory profiles, and then our standardized assessments that we always complete.
Okay, so like Nicole said, there's structured and unstructured. I am going to go into detail with some of the skilled structured observations that we do. When the kids come in for an eval, it's a lot of times what I will do is I'll ask the parent, are you comfortable with your child transitioning and separating from you to start? So I can bring the kiddo back, I can do standardized testing, I can kind of set up the environment, see what they do. Are they able to engage in a structured activity? What do their motor patterns look like? What does their posture look like? What does their attention look like? And so on. And then I'll have the parent come back for the parent interview. And this is a great time then to provide the child with an opportunity for free play. So like Nicole said, we're kind of watching, what are they going towards to play with? What are they choosing? How are they playing? Are they really rough with their toys? Are they playing with their siblings? It gives you a really good insight into maybe what life is like at home when they have their toys at home. Okay, so the clinical observations, these are the skilled observations I was talking about. I'm just going to go over a few of them to give you an idea of some of the ways that we can break those down. So prone extension is you're laying on your belly with your arms raised, your legs raised, and your head up. So in this case, we're looking, can they assume the position? Can they lift their head against gravity? Can they lift their arms and legs and they can't see their legs? So it gives you an idea. What is their vestibular function like? Like I said, are you able to pick your head up against gravity? What is the somatosensory system like? Are they able to, pick their legs up off the ground without seeing them? And that also gives us an idea with motor planning. You can kind of break it down. Again, as you do one of them, then you think, oh, I'm going to do this one next. I want to see what they do. Supine flexion, so laying on your back, touching your shoulders, and then bringing your knees up to your chest. Again, can they assume this position? That's a really good one for motor planning, for the somatosensory, because you're seeing, are they able to contact their shoulders? Are they able to bring them up? What is the co-contraction look like with this? And then the other one I really think is important that touches really on all three systems is finger to nose. So they have to put their arms out, close their eyes, touch, alternating finger to your nose with your eyes closed. In this case, are they able to keep their balance when their eyes are closed? There's your vestibular. Are they able to contact their nose? There's your tactile. And are they able to keep those arms extended while their eyes are closed too? There's your proprioceptive. They know where their joints are. So it kind of gives you some insight into all of those systems. Again, it's not always the direct answer. It's not always sensory integration, but this gives us, with this approach, more things to assess to see, what is this child doing?
Okay, then we have, like Jen said, during the caregiver interview, we usually like to give the kids, we set up different toys and to really look at what kind of type of play they're using. Are they engaging in functional play? Are they just picking things up and like dumping them up and there's like container levels? The organization of behavior. Are they able to plan how to play? Are they able to plan what they want to do next? And then just looking at, again, at the sensory processing, the praxis. Are they able to, while they're playing, are they able to complete the different motor tasks? Really looking at their postural control. If they're seated on the floor, how are they sitting? Do they have, poor posture? Are they sitting in a W position? Looking at the management of materials. Are they playing rough? Because if they are, they might have poor proprioceptive processing. And then the social and emotional, are they interacting with us? Are they interacting with their parents? Or if their siblings are present, are they interacting with them? And then the communication, are they coming up and trying to indicate that they need something, that they want to play with something else? Or are they able to communicate their needs? And then we want to consider any maladaptive behavior. So are they not able to communicate and they're having a hard time? Are they breaking down when they're not participating or they're not having one-on-one interaction? So those are the types of things that we like to look at during their free play.
And this is definitely, even in the initial eval, that child is just meeting you. Mm-hmm. So unless they're coming for another service, you're assessing at that point, but we're always, and I'll talk about that, but you're always continuing to observe what are they doing, because they might do something completely different in the evaluation and you think they're way lower than they actually are than when they come in for their first treatment session. So.
And then it just is like one of the observations for the interpretation. If we see a child that has a rounded upper back, they lean, they have poor extension, we might assume that they're under-responsive to proprioceptive input, which is affecting their sequencing, their feet forward movement, and their proximal joint stability. So this is just kind of like an example of what we look for in our observations and how we would interpret it.
So the standardized assessments, like I said, there's the sensory integration and praxis test. I was certified back in 2014, and I have used this very little. It takes about 3 hours to administer the entire sensory integration and praxis tests, and then another couple of hours to score. We can use it. I can use it. It's a plethora of tests within the SIPT. So I'm just going to do a quick review of those in a minute. But it's a lot of times you can get the same information from doing just a typical standardized test such as the BOT, and being able to, again, just observe what they're doing. You could do the bilateral motor coordination portion of the BOT or the balance, see what they do with eyes open, eyes closed. This SIPT will give you things more in detail. Often, again, if a parent requests this and they want me to do the SIPT, I will do it, but typically that's going to be an out-of-pocket fee because that takes up 5 hours of your day where you're not treating, able to treat other patients too. So it's going to be a little bit different. They're not really standardized assessments, but the sensory profile 2 and the sensory processing measures, the questionnaires, these you have to take with a grain of salt sometimes. The parents, a lot of times I'll just tell them just star if you have a question next to it. They'll say it has nothing to do with my kid or whatever. So in that case, I'll just say just write comments below. Write things that you're seeing. If there's something that sparks your interest that you see that concerns you with your child, now's the time that that's where you can write it down and then we can talk about it later. It just kind of gets them thinking a little bit more too. There's a caregiver one, and then there's a school-based one and a short form. So, and like I said, I'm not going to read all of these because there's too many. But they'll send out the PowerPoint later, right? And so you guys, if you want to skim through and look at the different types of tests within the SIPT, then you can go ahead and do that. But there's a lot and not a ton of time, so. Okay, so role of the therapist, like I said, it's constantly observing, it's constantly changing. So it's a lot of therapeutic use of self with these kids. With the modulation ones, a lot of times they're fearful or they're hesitant to engage with different activities. So you're building that trust and you're giving them opportunity to constantly play, but then maybe modifying the environment or throwing in your little bit of your activity that you want to do with them to challenge them. We're constantly assessing, we're constantly asking the parents, how are they doing? You know, a lot of times when we see these kids weekly, the parents kind of get lost in this is what we do every day. So reminding ourselves and reminding the parents, look at what your child's doing in your ADLs. You know, what is their hygiene routine like? Are they playing with their friends? What is school like? What are the routines like? Setting functional goals. We'll give you you guys will see a few of those in a little bit, and then determining, are we doing more of direct intervention, or are we doing environmental modification? And we have some videos of a kiddo that we see where you'll see where we kind of just modified the environment around him, and then some where we're actually using our bodies and directly intervening.
So with the interventions, we have a couple of things that we always want to present when we're using an air sensory integration approach. We always want to have a safe and optimal environment. We're lucky here as we have access to suspended equipment within our facility, but we have to, which is a huge part of sensory integration, but we have to be aware that if you're in early intervention or if you want to supply a home exercise program, suspended equipment might not always be available. So you have to really be able to be creative and be able to adapt your treatment to allow the families to be successful at home as well, because ultimately that's what we want them to be. We want them to be successful at home and in the community, not just with us being able to tolerate the things that we are doing with them. We always need to evaluate and modify the environment. This is ongoing. One day a child might come in and they might have low arousal and you need to be doing more excitatory activities, and the next day they might come in and they might be having a really hard time, their arousal levels might be up, and you need to change and modify the environment even if you had a plan. You always, when we're using a sensory integration approach, you want to use sensory activities. A lot of times if you're using air sensory integration, you're not going to have the child seated at a table doing a lot of activities. You might have them do that after you provide them the sensory integration, but you're not really going to be sitting at a table and not doing any kind of sensory exploration. And then play. So a child's occupation is play. So we always want to make our treatments play-based. It's always also, like we said, child-directed. A lot of times you can kind of go with the child, see what they're doing, and then modify and adapt to your treatment sessions to really have them actively engaging in the sensory intervention that you planned. And then active participation is a huge part. The child should always be actively participating. You should not be like putting their hands in tactile media when they have a modulation issue, because that's what you want them to do. Instead, you want to have them really actively engage it. Maybe that's starting off with doing hand over hand. They're helping your hand go through the tactile media, or they're driving their favorite car through the tactile media, and then participate and challenge them as they feel comfortable. And then when you're using an SI approach, you always want to make sure you're seeking an adaptive response. If you're using a sensory integration approach and you're not really seeing an adaptive response, which could be as simple as when you put them on a swing and there's more vocalizations, better eye contact, or better improved joint stability, then maybe it's not a true sensory integration deficit, or maybe you just kind of have to change up your environment. So you always want to make sure you're looking for that adaptive response, and then just providing them with the just right challenge. Make sure that you're challenging them, but not over challenging them.
And I think it's important that a lot of the parents come in right away, they're like, oh, I'm going to go buy a swing. And I'm like, no, please don't do that, because then it's not novel. Then it's not challenging their systems and really working on integrating those systems. You have to, that's what this whole approach is challenging them with novel experiences, and then hopefully, being able to form those new synaptic connections and making it more appropriate for them that they can engage in things at home. That doesn't mean they won't benefit from it, but you don't necessarily have to run and grab them, because a lot of times they don't know exactly what movements to do depending on what their child's deficit either. Like Nicole said, the adaptive response is always what we're looking for to determine whether or not it's a true sensory processing dysfunction. So it could be the smallest thing. It could be a second more of eye contact that you could take as an adaptive response to whether it's suspended equipment or going through an obstacle course and doing more proprioceptive based activities. You're always looking at their change, if their arousal changes, if their activity level changes, any slight, a lot of times with the vestibular kids, we'll do some vertical input. Is their posture improving with that? And are they able to sustain that after if we are sitting at the table? So it could be the smallest thing. Back to our slide, I just like to remind that. So intervention with sensory modulation. The biggest things we're looking at here, and I'll go into each system, but providing the appropriate sensory experience, modifying your social interaction, and then modifying the physical environment based on what their need is. The first one, we talked about gravitational insecurity, which is extremely rare, but these are the kiddos you want to keep very close to the ground when you're starting. They don't, they have this irrational fear of gravity. So you can have them close to the ground. You want to start with more linear based activities, or even just some vertical if you can, but have them these are the kids that you might have if you can get them on a ball or even on your knee with their feet on the ground and doing some vertical input first, and then slowly increasing to getting them to do maybe linear on the scooter, if they'll let you do that. There's seated scooter, you can use your feet to propel. So there's different things we can do with that. And then again, modifying the environment. So setting that up as they get more comfortable and you build that trust with them and they're starting to engage more in these sensory activities, giving them opportunity. Maybe they'll be the one to initiate climbing up the ramp or picking their feet up off the ground, making it very play-based and really encouraging the play in between. It kind of distracts them from what you're doing. And then intolerance to movement, like I said, this is the one that we see very, very commonly in our setting. So with these kiddos, we want to improve their ability to tolerate movement and improve their organization of behavior. So these are the ones that, like I said, might have delays in their gross motor skills. A lot of the PTs will come to me and say, hey, I've been working on this with this kid for a long time, but he still doesn't seem to want to move his head or crawl up a ramp or go from, walk across a different surface or a surface change. So these kids, then we're going to start out with minimizing any kind of vestibular input. We're going to start, if they don't have a tactile modulation, we're going to start with the tactile, and we're going to incorporate the proprioceptive. So maybe sitting on, I don't want to say a ball again, but using some putty and working through putty while they're sitting on a rocker board with their feet on the ground, or the Bosu ball. So you're incorporating some other type of those other types of input, and then slowly increasing that vestibular. So again, starting with linear with that is typically one of the best ones to do. So then it's slowly incorporating the head positional changes. Like I'll have kids do rolling on the ground and they don't realize they're doing, that, but they're still getting that rotational, facilitating the movement within the semicircular canal. So they're still getting it, but they're getting the prop and the tactile at the same time. So again, you'll see some examples of those later. So then modulation intervention for tactile. So for tactile defensiveness, again, we're not jumping right into sticking their hands in a bean bin or engaging with a craft using glue. We're starting out with doing more vestibular and prop if we can. So I might have these kiddos go through an obstacle course, crawling up and down ramps, going over crash pillows, doing things that really works on where are my joints at, what are my muscles doing. It gives them more of that input before we start to engage. My favorite thing to do, especially with some of the boys, they come in and they bring their cars in. So we'll do car washes. They want to play with that. They might not want to touch the car right away, but okay, you can hold my hand and I'll drive my car through the foam. And then we're slowly working into allowing them the opportunity to engage as they feel comfortable. This also a big thing with modifying the environment is reducing any kind of sensory overload that's not what they're doing. So we don't have many rooms that we can dim lights in North. Unfortunately, we have one room. So I like to go in that room if I can, so I can dim the lights, have a quiet space, and then I can engage them with some tactile play. The more overload you have going on outside, your arousal is going to be up anyways, and then you're going to have a hard time addressing that tactile defensiveness. And then proprioception as a modulator. This is just providing the child with the opportunity to use proprioception, but making it more rhythmic and controlled, so they're not just crashing into things. I might have them jumping up the ramp and then crashing into a pillow, making it very rhythmic, doing wheelbarrow walks to go to the next room to get ready. So you're providing them that opportunity, but not making it a little less unstructured and a little less like throwing yourself into a wall on the floor.
All right, so now we're going to talk about the sensory motor intervention. So that's a little, the blue one on the bottom, under registration and discrimination. First, we're going to talk about a child that has inadequate vestibular bilateral integration. These are the kids that have trouble using two hands together. A lot of times in the younger ones, you'll see these kids, they're not usually clapping at the appropriate age, not bringing their hands together. They have poor rhythmic, symmetrical movements of the arms, hands, and their feet. And they have just poor coordination of the asymmetrical movements of the limbs. And if a child's presenting like this, the intervention profile will really include activities that require that symmetrical movement. For the older ones, maybe working on pumping a swing, pulling on a trapeze with both upper extremities, or propelling a scooter. And then just really activities that require the alternating patterns, pulling on a rope, using hand over hand for tug of war, wheelbarrow walks, and then anything extension against gravity. So putting them on a scooter, maybe having them going down a ramp to really try to work on that prone extension. For the younger kiddos, it's a little bit more difficult getting them on a ball or swing with a bungee, so you're really doing those vertical movements. Pulling them on a wagon and then having them hold onto a rope to really try to elicit that bilateral integration, holding on with two hands, working on that co-contraction of the arms, being able to hold their arms up against resistance and maintain that grasp. And then a lot of the specific adaptive responses we would expect to see are more smooth, coordinated movements in response to the vestibular input, as well as improved bilateral integration. So some of these kiddos, if you're bouncing them on a swing, and they're trying to work on popping bubbles, before you bounce them on the swing, they might just be tracking them, reaching with one hand, and then you're giving them that vestibular input, and then they're bringing their hands together at midline, following the swing activity. So that would be a good adaptive response to look for. And then we have the child who has inadequate postural responses. They may have poor protective responses, very poor co-contraction of the muscles of the trunk, and then poor lateral flexion. A lot of times these kids have poor shoulder stability, poor joint laxity. And then these interventions, we would really want to combine gradient, linear, and angular movement as tolerated to improve those postural reactions. Again, putting them on the scooter, putting them on a wagon, and having them pull the different things. An adaptive response we would like to see is improved static and dynamic balance, improved postural responses, and improved trunk stability. But we have to keep in mind that that vestibular input can be used to modulate attention and arousal, but it is a very powerful sense. So if we're providing these children with vestibular input, we always want to be looking for an ANS response. Are they changing in color? Are they getting tired? Are they yawning? Are they having these negative responses? Because if they are, then we want to stop that immediately and then provide them mostly with proprioceptive input to kind of re-regulate them, because then we are not doing good for the child if they're receiving those ANS signs. And then we have the tactile intervention for tactile discrimination. As Jen said earlier, these are the kids that are clumsy, or these are the kids that are coming in and you're touching them on their arm, and they're, thinking you're touching them on the shoulder, or they have kind of like that poor handwriting as they get older and poor hand manipulation skills. Oftentimes they are, like Jen said, messy eaters. For these kiddos, we like to really just use full body tactile experiences. We like to have them a lot of times in the crash bed getting that somatosensory tactile input and the proprioceptive input, having them crawling through a variety of different tactile media to really elicit that tactile system. Sometimes we will put stickers on them and then have them with, maybe starting off with a mirror, removing the stickers, and then trying to find them without it. The adaptive response we would really want to see is improved body scheme, improved praxis, and then an improved relationship of the body to other objects. These are the kids that might be running into things all the time or kind of knocking things over. We would hope to see improvements with that. And then we have the proprioception. So, like Jen said, this is usually used as a modulator. So we want to use a lot of heavy work, pushing, pulling heavy objects and pushing them. And then we really want to facilitate muscle co-contraction. And the adaptive response we're looking for is appropriate use of force with toys, increased joint stability. So a child who's they play very rough, then we hope to see improvement in that rate of force of movement as we're providing our sensory integration.
So differentiating air sensory integration from other approaches, I'm not going to go into detail with all of these. The only one I really want to touch on is sensory stimulation. You hear a lot about using brushing, the Warburger brushing technique, especially in early intervention. This is not the same as air sensory integration. It's a different approach. So it doesn't typically require an active response that we're looking for with sensory stimulation. That doesn't mean it doesn't work. It's just a different approach. It's typically complementary. I feel like that it's used within the AIRS approach because this one is much more active and you're looking for that adaptive response. So they don't talk much about that in any of the sensory integration courses. And then the other thing we want to touch on is autism and sensory integration. So these kiddos that have autism, that's a characteristic. That's something that we always know that is going to come hand in hand is a sensory processing dysfunction with autism. The thing we want to really pay attention to is being able to differentiate the characteristic behaviors of autism versus a true sensory processing impairment that can be addressed through AIRS sensory integration. Again, this is all through her theory. So, but with AIRS autism, we are working on improving the adaptive behavior by reducing problems related to sensory processing, expanding the initiation and ideation, and then improving the functional and adaptive behavioral skills. So a lot of parents will come in and say, my child doesn't want to go to the bathroom, or my child plays with his feces. This is not typically a sensory integrative approach to being able to address that. Is typically something that just goes under that characteristic behavior of autism. Spinning and lining up objects. This is more perseverative. It doesn't mean that it can't be addressed or worked on using this approach, because we can work on expanding their ideation with toys and showing them these are things that we can do. But typically, if we're reverting back to that, a lot of times it is more of a characteristic behavior. And then some feeding issues. So the ones that are more rigid, that it's like, I'm only going to eat this because it's a certain color. That's, again, more of the rigidity and the perseveration rather than a sensory integrative component, where if it's a tactile concern, because they don't like the textures, then we're looking at it more from this approach. And then, again, being able to differentiate between, there's a lot of overlap between the behavioral specialists that come to us and us as OTs. The one thing is typically behavioral approaches go more from extrinsic motivation, and then sensory integration is more from intrinsic. Our primary concern with sensory integration is the child's experiences with the occupations and events, focusing on the underlying reasons for the problem behaviors, and then again facilitating ideation and self-regulation, whereas the behavioral approach is more of focusing on extinguishing those problem behaviors and compliance with adult structured roles, specific skill building through routine and practice. We have to work together. But I have a lot of BSEs that will say, well, I put a weighted vest on him to go through here. And I'm like, okay, well, I hope that you know that you should only be doing that for 20 minutes, or this is not, that you're doing this for the right reasons. Again, it's more of a strategy and almost more of a Band-Aid. But, those are things that we need, and we want that. We want to find what works for our kids. But I just think it's important to know there's a difference between saying that sensory integration, or we're using sensory strategies or sensory stimulation. So this is Christian.
So we're going to go a quick overview of Christian. He's going to be our kid that we talked about with our case study. He was referred by a physical therapist within our facility. Before we get into that, I'll give you the birth history. He was born at 30 weeks gestation via vaginal delivery. He did have a NICU stay for 1 month. And then when he was born, they had found cocaine and opioids in his system. He was placed in his great aunt's care following the NICU stay, and she is the one that brings him and participates in all his sessions, and she is the primary caregiver. Like I said, he was referred for occupational therapy by one of our physical therapists within our facility. He originally came for physical therapy due to his torticollis. That quickly resolved, but then he was showing delays in his gross motor skills. He was delayed, but Robin was able to kind of progress him through developmental milestones, but she kind of was saying that she's having difficulty. He was just learning to crawl when he came to us, but he wasn't really allowing his head to go into different positions, and he did not want to bear weight on his feet at all, with or without shoes. So she was suspecting some kind of sensory processing concern, so she referred us for occupational therapy evaluation. We completed the Peabody Developmental Motor Scale. We provided his caregiver with the toddler sensory profile, and we went through our clinical observation and our caregiver interview. This just gives you a quick overview. So he did score below average in addressing individual motor integration from the Peabody Developmental Motor Scale. This is a quick overview. We'll go into more detail later.
His attention was, of course, great. He's little, so you only can expect so much with the Peabody anyways, when you're trying to do it with one of the little guys, but his attention and regulation was horrible.
Yeah, and it should be noted that he was 14 months old at the time of our occupational therapy evaluation. These are the results from his sensory profile. We're not going to go into each individual subtest, but this is the way he scored after his caregiver filled out the sensory profile.
So it was a little scattered within that, but again, that's where you kind of take those with a grain of salt, and you're really doing a lot of your assessment. So the impairments that we saw, again, delayed gross motor milestones, self-regulation, and then praxis. When we did our evaluation, we came to find that his deficits led within the sensory motor section, the vestibular bilateral integration and sequencing, postural ocular, and poor proprioception. And then sensory modulation, he did have an over-responsive to tactile input. Again, we have to remember his birth history, he was born NAS. So it's tricky, but again, still trying to hit it at a young age. So let's see what we can do with sensory integration, and then we'll work on some of the other things later. So the goals we have were for developmentally appropriate play, both hands to clap at midline, and then I did have a sleeping goal. I don't know why it's not in here. And then a postural control and management of movement sensation. So really that's modulation of vestibular input, but insurance doesn't like to hear that. So management of movement sensation. Wait, I don't want to have you ask questions yet. I want to pull up the videos so you guys can see. So this was Christian the first time that we, can I just click recommended? Yeah. Okay. Okay, so you see he's not really bearing weight through his feet. He's a little floppy. Kind of looks a little messy there. So, second video I want to show you, this is one of the ones where we started. So we had him, I don't know, oh, the sound probably won't work. Because you can hear him, what? Oh. Because you can hear him start to imitate too, because speech and language skills were also delayed. So at first we do a lot of just reaching with one hand, and as we continue to do it, so we're doing the vestibular stimulation with the otoliths first, doing the bouncing, and then adding in some of the arc, and then working on the two-handed play with that. He's so cute. We love him so much. So there's that. And then you see him looking back at me, so there's some really good joint attention there. Here is more of the direct too. So this was a couple weeks later. I put him on the tire swing, had him, giving him opportunity again for that vertical, but this time it was more active. He's having to put more through his, and there he goes. So there's that. And then let me do, here's again more of the direct vestibular tactile proprioception. So we were doing rolling. So we have that, and then I just want to quick get through all these so I have a second for questions. We were doing some tactile play here. Watch it not work. So again, working on some of the bilateral skills, incorporating the tactile. This was after doing more of the rolling, some of the proprioceptive stuff. And show you this one. So with our feet, so we're doing a lot of play. We're reaching for the ducks. We're using, again, both hands. We're doing some reaching, so some postural stuff.
And this was a few weeks after.
Yeah, this is slowly progressing.
Slowly progressing, yeah. So we didn't just stick them in. Do you have the one going up the ramp after Robin's video? Where he's bouncing on his feet, bare.
I don't think I do.
Oh.
So this is one of the ones that's a little bit more modifying environment. So I give him some of the bouncing, and then he crawls down, and you'll see him crawl up. So you're setting up things that he can do. And then last thing. So we have that one, and then our present one. So here's Christian now. So that's his PT. So of course you have to take just like development into account, but then also providing him again with it. So now we're walking. So he's awesome. Does anybody have any questions? We had him, I started him in February of 2019.
And he was seeing 2 times a week, and he recently went down to 1 time a week. So
he's down to 1 time now for OT. I like my Dwight Schrute picture on there. So, all right. Does anybody have any questions? I know it's a lot of information. It's a lot of talking. We were so worried because we're like, it's just so much information, but we want to give people as much as we can about it. Again, it was hundreds and hundreds of hours of learning for this. So it is hard to kind of cram in. Yeah. Sure.
So a child that is having feeding difficulties and is well beyond the child's 2.5 and still having swallowing difficulties, has had speech speech therapy greater than a year and a half made no advancement.
Okay.
Would it be appropriate?
It would probably be beneficial because, I mean, you want to look at the muscle tone and everything too. So and it's just looking at it, it would be appropriate probably to at least have an evaluation to see, is there something going on? Has the child been to GI?
Oh, yeah, GI.
Okay. So
ENTs,
they've been to plenty of doctors.
Physical
Yeah.
thing. And speech therapy finally said, I think it's a sensory.
And it very well could be a component, so it would definitely be worth an evaluation. It's hard to say because, like I said, it's so different with each kid. So we would then provide them with those experiences, see how the child responds, and see if it is a true sensory processing dysfunction. Anybody else? Okay. Thank you all so much for coming. I'm just distracted about to see the last video.
Thank you. Evaluation for dysfunction because oftentimes there is that other piece that's not related to the adaptation, massage.
What?
Yeah.
Yes,
Drop guys, it's over with.
it's a strange, so it's a range and,
Yeah.
there's no
See you guys
Yeah,
later.
you just can see.
I mean, it doesn't matter. No, but I mean,
Yeah,
yeah,
it's hospital, big family.
Oh, which are amazing.
Right,
Yeah.
he has a feeding tube.
Okay.
Because he constantly aspirated and developed pneumonias and it was a mess.
Elizabeth, should I stop the recording on this?
Yeah, I'll be right there.
Okay.
He does okay with solids, but he can't do liquids. And I need
That's okay. I hope it worked.
and his speech is